Okay,
They
okay.
seem to have a West Coast Lyme. And pandas.
Okay.
A patient of Dr. Harani's.
Did you
So-
come to see me and then I wasn't in clinic? It was on like a Monday, a random day? Am I making
Yeah,
this
and
up?
then I ended up seeing Dr. Wu.
You ended up seeing Dr. Wu, right?
And then I went to it in a hospital.
Okay.
But I was a little offended because the person who did like the session
Okay.
was
Yeah.
who did the intake. He was a little bit like, oh, the holistic thing, and
Okay.
it's just my kid
Okay.
is like, he's like now he's running out of the house and
Okay.
trying to run into the
Okay.
traffic. So anyway,
No, I didn't. No, you look so. We'll talk.
Gateway.
Okay. No, we'll talk. Okay, we'll talk after, or are you gonna?
Perfect, yeah, I
Are you gonna
came
be
down
here?
just to see you.
Oh, that's so nice. Okay. We'll talk after then.
Okay, thank you.
Okay.
Yeah, so
Oh. Should I start? Yeah. Yeah. 3 o'clock? Yeah. Okay. All right, I'll start. My name's Raj Rajaraman. I'm an epilepsy doc at UCLA. I'm training pediatric epilepsy. And we'll talk about difficult to treat epilepsies. I kind of do in two ways. It's kind of the hows and whys. So why do people have epilepsy and how you can treat it? So there's kind of two sides to everything. All right. So in terms of the whys, why people get epilepsy, a lot of times it could be genetic. Now, when people have a genetic cause, it doesn't necessarily mean a parent has and it gets passed down. Sometimes when the egg and the sperm kind of come together, there's a mutation, and then you have a new type of epilepsy, or you have a child who gets epilepsy. So it doesn't necessarily mean it gets passed down, but it occurs during fertilization. Okay. In terms of genetic testing, there's a bunch of testing you can do. So because it's hard to treat epilepsies, I'll cover the things that you should kind of get done by your epilepsy doc to figure out why. Okay. So there are kind of three genetic tests. One is called a chromosomal microarray, which looks at kind of big copies of genes. There's the epilepsy panel. So this looks for copies. This looks for kind of specific genes that cause epilepsy. And then you have exome sequencing. Now, exome sequencing is looking at the whole array of genes, trying to find the one gene that's kind of causing your epilepsy. So these two are kind of targeted, and this one's looking kind of everything and trying to find a cause. So genetics is one cause. Another one is a brain injury. Or structural. So let's say you get in like a bad car accident. That can cause epilepsy if you have an injury to a brain, so TBI. Let's say you have a birth injury, and we call that HIE, or a hypoxic injury. Let's say it's a very difficult pregnancy and you got a brain injury. That could be a cause. And then there's other kind of structural things like tuberous sclerosis, or there's a lot of diseases like hemimegalencephaly, lots of things where you get brain malformations. Okay? So you can do genetics, you can have brain injuries, you can strokes is another good brain injury. Usually, just because I'm a pediatric guy, so strokes aren't as common in pediatrics as versus adult. But if you have adult stroke, a lot of them can end up having seizures. Go ahead, please. It's possible. So it's more rare to have strokes in the pediatric population versus adult. But that can also cause, any kind of brain injury can cause seizures.
Is this topic hard to treat epilepsy?
Yes, yeah. If anyone has questions, just please ask. So genetic brain injuries, and sometimes there are metabolic causes. Sometimes there are infectious causes. So if you have like meningitis, that can cause seizures. And then a lot of times we just don't know. And when you're at that point, it's probably because the genetics isn't there yet. We don't have a genetic explanation to pinpoint, say, okay, this is what's causing the seizures. But also at the same time, a lot of times if you don't know the cause, that's actually sometimes a good thing. Because if you have a genetic cause for your seizures, or if you have a brain injury that's causing your seizures, that means it's something that you're going to have with you your whole life. If you don't know what's causing them, it's not that obvious or apparent, that you can say, okay, maybe it's something that's not going to be with you your whole life. It might go away with time. So that's a good possibility that you might outgrow them. Go ahead, please.
What about microorganisms, mold, fungus, Clostridium or something?
So there are, that would fall under kind of infectious. So yeah, so some people have like fungal infections. Some people get something like cocci, or you go get toxoplasmosis. There's different kind of infectious causes too. Any questions so far about causes for seizures? So these are the major ones: genetic, brain injuries, metabolic, infectious, and sometimes we just don't know why. Okay. Sleep, not as much as sleep. So poor sleep can cause seizures or can provoke seizures. So if you stay up the whole night and then you're known to have seizures with insomnia, there's an epilepsy called juvenile myoclonic epilepsy, which is you see in adolescents. If they stay awake for the whole evening, sometimes they can have seizures that get provoked. So that could be a trigger for seizures. Okay. So that's the why. So now we could talk about how we could treat epilepsy. Okay. So we'll start with the typical ones. So there are medications that can treat epilepsy. Now, I imagine everyone who has a kid or who has epilepsy has been on medications. There are over 20 epilepsy medications. And just because one medication or two medication doesn't work or doesn't stop the seizures doesn't mean you should kind of stop trying the different medications, because all medications have different kind of mechanisms of actions. So if I see a patient who had tried one drug and another one and they're still having seizures, I look for a different medication who has a different mechanism of action. So I think that's an important thing, is the mechanism of action, which is the way you treat them or the way to try to stop them. Each drug has a different kind of way, and they fall into classes. So some drugs work one way, other drugs work another way. Third type of drug works this way. So you want to, when you speak to a doctor, you guys make sure that the physician is trying different kind of classes of medications, because you want to attack the seizures in kind of different angles. Okay. Now let's say you try medications and you're still not having full control of your seizures. What's the next option? So at UCLA, we're a level 4 surgical center, which means that we do a lot of epilepsy surgery, trying to cut out the part of your brain that's causing seizures. Okay? So surgery, and now there's different kind of surgical options too, but the goal is to find a part of the brain that's causing seizures, see if you can cut it out without causing long-term deficits or injuries. Okay? So you're trying to find the part that's causing seizures. Okay, so now how do we figure out what the part is? So we do an EEG, and we do the video EEG, and we try to capture the seizures. Okay? So let's say on the EEG, it points to the right side of the brain is where your seizures are coming from. Then we do MRI, which looks for structural changes. And then you say, okay, the MRI points to the right side of the brain. So right here, the EEG, the MRI, points to the right side. Then we do a PET scan. A PET scan checks for glucose. So your brain uses sugar. So you want to look for the part of the brain where the sugar is low. Because if the sugar is low, you can say, okay, that part of the brain isn't working as well as the rest of the brain. So let's say the video EEG said the seizures came from the right. The MRI, there's something on the right side of the brain. Then you do the PET scan, and the sugar is low on the right side. And you go, okay, everything's kind of pointing towards the right side of the brain. Then we got to say, okay, where is it coming from? What part of the right brain is those seizures arising from? Now let's say you want to make sure that things that are important to you doesn't get cut out, okay? So what's important to everyone? Does anyone want to say? I'm sorry? Memory? Perfect. So memory is one thing that's important. Anything else? Speech and language. I'm sorry? Hand. Perfect. So motor. And those are kind of the three major things. Now some people say vision or occipital. But there's a lot of shared parts with vision. So you can cut out large parts of the part of the brain that does vision, still be okay. Memory, language, motor. Now in pediatrics, the good thing is that language is very flexible. So if you have epilepsy surgery at a young age, you can kind of compensate and the other parts of the brain take over. Same with memory, you kind of have memory on both sides. If you have epilepsy surgery at an older age, you have difficulty compensating as well. But because my specialty is pediatrics, we do a lot of epilepsy surgery in peds, we kind of want to look for surgery as early as possible so you can compensate as you get older. Now motor is something that you can't always improve. You can do a lot of therapy, there's a lot of things that you can do to kind of improve things. But if you do surgery early and you affect the motor area, then it'll take some time for it to get better. And you might not get back to exactly where you were, but it does take time. Question? So usually we like to see sometimes language under the age of 5 or 6. Sometimes you could do older, but language is usually the younger ages is as flexible, it's the most flexible. So this is what we call kind of our pre-surgical planning. So you come to me and you say, you know what, during the seizures, the left arm always gets stiff. And that makes me think it's always coming from the right side of the brain. So, because the left side of the body is controlled by the right brain, and the right side of the body is controlled by the left. So we do the EEG, which points to the right side, MRI, the PET scan, everything's saying right. And then we have to do testing to see if any of these parts are involved. Because you want to make sure if we're going to cut things out, maybe we don't want to affect all these things. Or we said, you know what, my kid has 80 seizures a day. It's really ruining his life. And we do the testing, and it comes from where the hand is. And you say, okay, you know what, I'd rather sacrifice hand function on the right hand in order to get seizure control. And that's a long conversation which I have with families about what is going to be the kind of final verdict about what we want to do in risks versus benefits. Okay, please.
If the affected area is involved with, say, like sleep and arousal or respiration or cardiac functions, are they ever candidate for surgery because those are so basic to?
Well, you would have to see how much. It's hard to pinpoint exactly where those seizures are coming from. If it's from like a respiratory issue or stuff like that, you would probably need a little more involved testing. And there's a lot more. This is kind of the first battery of testing. There's a thing called like a WADA exam, and then a functional MRI, and different other kind of testing, which help you with the surgical planning. And then our surgeon is Dr. Fala, and he sees all our pediatric epilepsy surgery, our neurosurgeons. Okay? So this is surgery. Now let's say you come into us and you say, we do all the testing and none of it is in one spot. Or it's coming from 3 spots or 4 spots. We're not going to be able to do like a clear-cut surgery. Okay? What are your other options? And these are considered surgical options. but they're not the big surgery or the brain surgery or the hemispherectomies. So they're called devices, and I could just erase this. Okay. So and I'll do them in order of how long they've been around. So VNS, which is vagal. This device, these are devices. It's a device you put under the skin. It's a wire that goes to your vagus nerve, and the nerve goes up to your brain and sends a constant signal stimulating your brain to try to stop the seizures. Okay? So it's a constant signal of electricity and current trying to prevent the seizures or trying to stop the seizures. Okay? That's a vagal nerve stimulator. The other one's called RNS, which is responsive nerve stimulation. It's a device where you attach the parts of the brain which are causing the seizures. So let's say you know that your seizure is coming from the left side, let's say the left front, and you decide, I don't want to cut out that part of the brain. Let's say, I don't want any kind of deficits, anything like that. This thing is that where you put a device on the left front, and it constantly stimulates on that area, but it also records the EEG. And if you see a seizure on the EEG on the brain, it will try to stop it. So it's responsive because it actually picks up the seizure and tries to stop it. Any questions about these two? So this one is a VNS. It's a device that you put under the skin. The wire goes to your vagus nerve and constantly stimulates. And it also has this magnet where if you have a seizure, you swipe the magnet and it sends a stronger pulse to try to stop the seizure. Now, that's not, you don't open up the brain or anything like that. It's considered surgery because you put the device in and it goes to the neck. This one, you open up the skull. You actually put a device on the brain to stop the seizure on its spot. So this one's a little more invasive. Yes?
The same battery of tests for the device type surgeries as it would be for typical brain surgery?
What was it again? I'm sorry.
Would it be the same battery, the same type of testing and scans?
Yeah. And then the next one is called deep brain stimulation, or DBS. This is a device that goes in the basal ganglia and it goes out and stimulates. This has been on the market for a long time for Parkinson's. So some Parkinson's patients have a deep brain stimulator to help with their movements, but now they're using that also for epilepsy. So these are the devices. So we covered some medication, then surgeries, and then we have devices. Now I consider the devices a little bit separate from surgeries because the before-osoma is where you actually cut out a piece of your brain. These ones you don't actually cut pieces out, okay? Please.
About 6 years ago, I read about a doctor at UCLA that was putting something on the forehead and for the trigeminal or something nerve, and it was working for seizures and depression.
Sure. So
I get one of those devices.
So trigeminal nerve stimulator is a device that was under trial for seizures. TNS is the other name. I could talk to you afterwards about TNS and its effectiveness with epilepsy, and I know it's being kind of investigated. But I've never.
Invasive.
No, it's not invasive.
Can we get one?
I have to see if it's approved for and what type of epilepsies. But we could talk after about that one.
Okay.
Sure. Okay, so medication, surgery, and then devices, and then diet. So this is the fourth kind of treatment option. So diet, now there's the classic ketogenic diet, which is high fat, low carb, low protein. It is been shown to be helpful with epilepsy. It's been around for a very long time. You know, a lot of families, there's a lot of families who are already on keto. It is pretty strict diet. It's kind of like a medication where you have to take it. If you skip a meal, it becomes an issue. So, you know, it's almost like skipping your medication. So it's important that you kind of adhere to the diet. There's vitamins that you have to take with it. There's some blood work, but it's been effective with epilepsy. So it's definitely a consideration. We have a ketogenic diet team at UCLA where you meet with them and they talk to you about whether keto is the right fit for your family, what it's involved, how it's going to kind of affect things. Now, there's a less strict diet, which is called the modified Atkins diet. Now, when I say it's less strict, that means you get a little more of the others, but it's still a fairly strict diet. But most of my teenagers, adolescents, sometimes they're more prefer this because there's a little more variety in terms of when you can eat and how much, and it's not as strict in terms of weighing your food and figuring exactly. But it's still a strict diet, but maybe not as strict for the older kids than keto. Gluten-free is a different one, yeah.
But I mean, the keto diet, can you eat gluten on that diet?
Can you eat? No, I don't think so. No, because it's no carb. Yeah,
No, I mean,
yeah.
half a loaf of bread is very foreign, but can you eat gluten?
Well, the low carbs is pretty low. So like a slice of bread is how much you can pretty much get it with keto.
What a piece of bread, I think,
Yeah. But they'll kind of talk to you about how much you can do for that. There are other diets. So there's the low glycemic index therapy, and then there's kind of the diet. So there are other options that you can kind of do, which are a little less strict, but ketogenic diet is kind of the one that has the most evidence behind. But there's a diet team at UCLA, and a lot of other level 4 epilepsy centers have diet teams, and it's a good option to talk to about. Okay, so we covered medication, surgery, devices, diet, and we kind of covered the causes of epilepsy, which were genetic, structural, we could say metabolic, infectious, and then sometimes we just don't know. Okay, does anyone have questions so far? Please.
If it's found that you're not a good candidate for a more traditional surgery, is it possible to do a combination of the devices to try?
Yes. So I usually recommend to see if you are a conventional surgical patient initially and rule that out if you're not before you do the other devices. If you have an RNS device, it's difficult you can't do an MRI afterwards. If you have a vagal nerve stimulator, you can go insert in MRIs. The MRI scanner has to know what kind of device you have. So I recommend doing the conventional surgical approach, and if you're not a candidate, then start considering the other devices. Sure. 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 Now that's a great question. So the kind of national consensus, if you failed 2 or more medications, you should be evaluated by a surgical center. The national wait to be evaluated by a level 4 surgical center, sometimes the average is 19 years. And some adults have never been kind of considered for epilepsy surgery. And the kind of the flexible and the plasticity of the brain is usually at the younger ages. So if you're failed about 2 medications, I usually say at least let's get evaluated. And when you get the evaluation, it's pretty much initially you get the video EEG, capture seizures, get an MRI scan, the PET scan, and it's kind of the first run through. Any other questions? No? Yes, please.
Types of epilepsy
Sure. So now, let's say you have a really big stroke or a very big injury early on, and it's a large stroke. There's various surgeries you could do. So the one I'm talking about is called a hemispherectomy, where you actually disconnect or remove the hemisphere. Now that's the biggest surgery that we do in pediatrics, but it also has the highest rate of success, and it's really kind of risk benefits. So let's say the patient has a huge stroke on the right side of the brain, and we do all the testing. And the right hemisphere is not doing anything. It's very minimally effective, and they're already weak on the left side. Then hemispherectomy is your best chance of getting seizure control. There's a booth here. It's called a Brain Recovery Project, and it's Monica Jones is the president or the founder. Her son had a hemispherectomy, and they talk about hemispherectomies and how it's an option for some families, and the success and the things you have to think about when going that route. So hemispherectomy is one. The most common type of even seizures and surgeries is temporal lobectomies. So hemispherectomy, temporal lobectomies, and then there's just focal resections, where you just cut out parts of the brain that are causing seizures. Now, these surgeries are best for focal seizures, which makes sense because your seizures are coming from one part of the brain, and then you can try to find out that one area and then cut it out. If you have something called generalized seizures, which means that your seizures are coming from all over the brain, the chance of cutting that out is not there. Okay. Please.
Before you get to anectomy, we're actually removing something from the brain. Would, say, cutting the corpus callosum be effective for particular types?
So corpus callosotomy has been done a lot, and we do it a lot with drop seizures. We try to infantile spasms. It is, and now every center has different success rates. Some people say it's more successful than others not as much. It's more of a palliative surgery, because if you're going to cut out the part that's causing it, then your success rate is going to be way higher than just kind of disconnecting. And it's not like a full disconnection. You still have other ones behind that corpus callosum. So it's definitely an option. It's more considered a palliative option. Now, there are people who've had a corpus callosotomy and become seizure-free, but it really kind of depends on the situation, too. Any other questions, please? Yeah. What is? I'm sorry. I would see if you're a candidate. So now, let's say you're on a medication, and it's, I don't know. So let's say, you're on medication A, right? And then you go up 2-3 times because they keep having seizures, right? So you try it, you keep going up and it's not working. You try medication B, and then let's say we go up 1, 2, 3 times, still having seizures. And then at that point you could say, okay, I've tried these 2 medications, we tried it, increased it, and it hasn't helped at all. Then I think it's okay to start seeing whether surgery is a possibility. Now, some medications aren't always the best for a certain type of seizure type. So if you have generalized epilepsy or generalized seizures, you don't want to use a medication that's kind of focal. Or you don't want to use, so you got to kind of think about, is the medication the right medication for your kid? And that's my job as a doctor. You guys don't have to worry about it. That's my job as the doctor. Make sure it's the right medication for your kid. Tried a couple of medications, and then we're saying, okay, we're not getting seizure control, and it looks like, okay, every time he has a seizure, his right arm always goes up, or his head always turns to the right. That makes me think it's coming from the left side. So we should kind of really pursue it and see if we can pinpoint where it's coming from. Now, let's say we pinpoint it, it's coming from the motor part, which controls arm and leg, and you say, okay, you know what, I really don't want him to have a limp or any kind of weakness. I think his seizures only happen, not that often. Can we pursue other options? Then we can start talking about it. Okay. Yeah. No. So when I would talk about this, like a year or two ago, I wouldn't consider CBD under the category of medications, but now it is prescribed medication. So CBD, and now it's the name's Epidiolex. That's the pharmaceutical prescription. It's approved for Dravet syndrome, and then Lennox-Gastaut syndrome. Have you guys heard of these epilepsies? Yeah. So Lennox-Gastaut syndrome just means multiple seizure types. Developmental delay. And then the slow spike wave pattern on EEG. So, pattern. This one? Who diagnoses it? So if you tell me he has tonic seizures and drop seizures and different seizure types, if you have intellectual disability or developmental delay, and then you do the EEG and you look for the slow pattern. So that's what I look for on the EEG. If you fit all three of those things, then you have Lennox-Gastaut syndrome.
So
Yeah.
it's not a genetic test,
It's an umbrella diagnosis, so you can have different genes that can cause Lennox-Gastaut syndrome. Yeah. I'm sorry, I can't hear you. Sorry about that.
We're actually not on this drug right now.
Okay.
But we don't have any of those symptoms. It was just because we tried 6 different drugs and nothing worked.
Okay.
We were approved.
Okay. So it depends also kind of how your kid is. So if he has multiple seizure types, history of developmental issues, and have a slow pattern on the EEG, that's enough to say, okay, he fits or she fits that syndrome, but they maybe never been diagnosed with that. But if you have that in your chart, it helps gets the medication approved. So.
Is the cause of that condition known? The vitamin deficiency?
So Lennox-Gastaut syndrome can be caused by genetics, birth injury, any kind of any cause of epilepsy can cause Lennox-Gastaut syndrome. It's more of a blanket term. It's kind of a description of the patients. If you have multiple seizures, delays, and the slow EEG, then you say, okay, that kid has Lennox-Gastaut syndrome, but it's kind of like an umbrella term. Does that make sense? Yeah.
Is there any year that was first identified as the syndrome?
It's been around for decades and decades. Yeah. It's been around for a long time.
Before 1940s?
No, not before 1940s, but maybe 60s, 70s.
After the introduction of baby vaccination?
Yeah, it's been around a long time. Yeah. Anything else? What time is it? Yeah. So you can have multiple seizure types coming from the same spot though. So I'll give you an example. So tuberous sclerosis, which is a pretty common epilepsy. It's a genetic epilepsy. You have the TS mutation that causes it, but that mutation causes a structural change. So in the brain, you get these tubers. Okay. And then with these structural changes, you can cut them out. So even though you have something genetic causing your seizures, you can cut out that structure that's causing them, and they can have a bunch of different seizure types. So just because you're genetic doesn't mean it's generalized. You can have a genetic epilepsy and sometimes be focal. It's not always the case, but
Like in his case, we feel that.
okay.
They didn't find it.
You never found it.
That was just as it was. You're here for 2 years now.
Now you have seizures.
2.5 years.
Okay.
He has all of the electrical.
Yes, what I'm sorry? Yes, okay. Did he ever have a pre-surgical evaluation? No. Did they ever capture the seizures on the EEG and said it comes from one part?
Yeah.
Okay.
They did tell me exactly. I forgot exactly.
Okay.
What is the medication of that?
Okay. We can talk after and see what options are.
Then if they remove that, for sure he's not going to stop, right?
Well, it depends on, so you have to do more of the testing to see where language is. So most people, language is on the left hemisphere. There are testing to point out where you think language is coming from. So there's more testing to really kind of nail down where you suspect language is.
What is the name of the testing?
For language, so the WADA testing is one. The other one's called functional MRI. And then neuropsych testing or neurocognitive testing can help try to pinpoint where language is. Yes?
Studies being done that if you have a mutated gene and you, by testing, you know what gene it is, that there is a gene fix out there that you guys are working on for different epilepsies.
So there's
So it's not doing surgery with something that you put on.
it is there's not a specific gene replacement therapy yet. There's a lot of research for a lot of genes, and it's really kind of spread out, trying to figure out, is there a way to replace a gene or modify a gene or figure out from that standpoint. There's nothing kind of FDA or definitely approved yet, but there's always research looking to try to fix the gene. Yeah. Okay. Okay. Did she didn't have the gene, or no one had the gene, or no one? So did they do whole exome sequencing? So whole exome sequencing is all the genes. If that's negative, then we could say our research and our knowledge of what genes cause epilepsy, she's negative for. Now let's say 10 years from now, we'll discover a lot more genes. Then we could repeat the exome testing and see if it's there then. So it's kind of constantly changing. So I usually recommend patients, let's say I had exome testing like 2-3 years ago, ask the lab to repeat it to see if because we discovered new genes. Okay. Yeah.
Is it normal, like, if you're getting genetic testing done, that if you have a mutation that is there in family, but then you also have about 15 other genes that are unknown to science?
Yeah. So
Is that normal?
So what you're describing is called variants of unknown significance, and you'll see I find them annoying, you find them annoying, they're just annoying things because we don't know if they cause epilepsy, but we don't know because it hasn't been reported yet. So your kid could have the first variant of unknown significance, and he could be the first case where that mutation caused epilepsy, but it's never been reported before. So I always refer, if I see a variant of unknown significance or maybe I always send it someone to genetics because they're really well more equipped to tell me, okay, that gene really is nothing or that could be something, and then they can pursue. So I always say if there's anything positive or semi-positive, go to genetics. Please. Gastaut syndrome? Yeah. Not really. Pretty much just an EEG and then a history. And if you have a delay and multiple seizures and then the EEG pattern, then you can kind of say that's Lennox-Gastaut syndrome.
My son had the two first times, but he hasn't had EEG in the last 2 years.
I think it's worth repeating. Now, so Epidiolex is not the only medication for Lennox-Gastaut syndrome. There's a lot of them. So, and a lot of times the medication you're on is improved for seizures associated with Lennox-Gastaut syndrome. So, there's multiple meds that help with LGS. So, even if Epidiolex is not the one, there's other ones you could try. Yeah, please. That's a good question. So, there's a whole list of medications that are kind of for it. It also depends on what seizure types they have. So some are better with drop seizures, some are better with focal seizures, some are better with absence seizures. So because Lennox-Gastaut syndrome is associated with so many seizure types, it's kind of important to know what kind of seizures he has.
Is
Phylbitol is a good medication for epilepsy. Yeah.
for the
Lennox-Gastaut, yeah. Is.
Do you have to have the slow spike all the time with every EEG or just sometimes?
It's usually seen on most EEGs or once you start having it on your EEG, it's hard to get rid of. So if you do an EEG, it's usually there if you have that diagnosis. Yeah.
So when the word autoimmune encephalitis comes up a lot,
Yeah.
like Lyme,
Yeah.
type
Yeah.
suspicions and blood work, and also like my son has autism, but he's more ADHD, Asperger's, and sometimes I notice when he is really getting upset about the one thing that we're all not with the program and what he's planned for the day.
Yeah.
Then he almost throws himself into these episodes. So, what is that? Are some kids that diagnosed with Asperger's type or high functioning autism? Are they also more prone sometimes to seizures than some other kids?
That's a good question. So sometimes up to a third. So 1/3 of kids with autism can have epilepsy. So they are pretty linked together. So I'm not surprised to hear that. Now, you mentioned autoimmune. So that's where you have antibodies that kind of attack the brain and that causes seizures. And sometimes people have autoimmune epilepsy, they have different treatments that might be helpful. So there's things like, now if you're diagnosed with autoimmune, there's things like steroids, IVIG, and that's kind of a different pathway for treatment options. But that's a different route. If that's yeah.
What does that mean, autoimmune?
So antibodies, which are things that float in your blood, start attacking your brain. So kind of things that attack your brain is often considered autoimmune.
Is that something you can test for?
Yeah, so there are a known, so Mayo Clinic has a autoimmune panel. And that has a list of antibodies associated with seizures. Yeah. So that's a consideration. Anything else? Yeah. Sure. Okay.
She's on her second pill medication. We've seen some improvement on the keto.
Okay.
But she's still having seizures. She's been full on ketosis for 6 months now. And just 2
Okay.
So I'm just kind of looking what's next
Okay.
in that sense.
Okay. So if she has, yeah, just from what you're telling me, so absence seizures are generalized seizures. So it's not coming from one part of the brain, it's coming from everywhere. So surgery is not the typical part where you're talking about cutting out, is not an option for her. Now, the medications, you kind of have to see if they're good for generalized seizures. And if those aren't helping, you could try other medications which are good for generalized. And then if that's not an option, then keto is a good option you mentioned. So VNS is an option for absence seizures. That's where you put the device here, it goes up. But if those two medications haven't helped, there are other ones I could talk to you after about what are the options.
I just kind of feel like, we kind of ignoring them. They say after your second pill medication, it's kind of hard. So then we did we've been doing keto for 6 months.
Yeah.
And it's still, it's reduced.
Yeah.
But there's still, the whole point is, seizure-free, right? The thoughts on seizure.
Yeah.
She was diagnosed with drug-resistant allergy.
Yeah.
And so it's kind of like, okay, but we're still having seizures, and now we have a breakthrough, like a convulsion.
Yeah.
And I was kind of like, okay, so now, and I know we go and send them out to see a neurologist.
Okay.
And I was just wondering, what happens then?
There are other medications, and there's sometimes it takes time. Also keto, at our place, we say you gotta try keto for at least 3 to 6 months before you bail on it, because sometimes there's improvement with time. So sometimes 6 months to a year out, you can see some extra bonus from keto.
Yeah, we're at 6 months, and I've seen the improvement.
Yeah.
But I was just kind of like, and then 2 weeks ago, I was like, damn, she had a convulsion seizure.
Yeah.
Just interesting.
So kids with absence seizures, you are at risk for generalized convulsive seizures. It's not the majority of kids. Most of them just have the absence. But I always kind of warn families, you got to keep an eye out for those generalized seizures. So I'm not too surprised she had a convulsive one, but I would probably try other medications, and I could ask, we could talk after about what you've tried. Okay. Please. Was it? Okay. Yeah. Okay. 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 Yeah, well, I could talk to you after. It depends on what medication it is. Rolandic epilepsy is it's actually, if it's definitely Rolandic, yeah, I would make sure it's Rolandic, because that's one of the epilepsy types that most kids outgrow. So that's a good one to have in terms of epilepsy. But I would make sure that's Rolandic and what medications you're on. We could talk after about it. Okay, sure. We have time if anyone wants. Do you guys, when you guys look at EEGs in your bedside and there's EEG going on, did anybody ever tell you what the squiggly lines mean or anything? Yeah? Do you guys want to know, or? Yeah? Okay. I can't tell you everything about the squiggly lines, but I'll
When they say, saw a friend, he did it,
yeah. Yeah.
he said that he saw one son I told about.
Yeah.
He began to went back and looked at it and said, I didn't see epileptic, Dr. Villett looked at it.
Yeah.
But he said abnormality.
Okay.
So, associated with autism. So,
Okay.
I don't know, what does that mean?
Okay.
It comes from each
Okay.
It looked like nothing
Okay. Yeah. Oh, yeah. So EEG just measures brain waves and electricity, right? So these are what the lines look like. Now, there's letters on the side. So there's F for frontal, central, temporal, parietal, occipital. So these just different letters point at different parts of the brain. Now, there's on your EEG report, they'll say something like T3. So T means odd, which is the left side. And if you have a 4 or an even number, that's the right side. Okay? So if you're having abnormalities coming from the odd numbers, that means is coming from the left side of the brain, and the even is the right side. Okay. Now, on the EEG, there's something called interictal, which people talk about. Interictal just means not during the seizure, but all the other time. So it's just kind of your background brain waves, your background activity. Ictal means seizure. So if you're on the EEG report and it says, oh, the child had interictal spikes on like T3, so that means the temporal, and then 3 is the left side, so left temporal. Now when they say spikes, so this is your normal brainwave, and then you'll have like a spike area, and then you have a spike area. Now, the spikes aren't seizures. Spikes just mean that's abnormal activity on that area. So while someone's sitting there and you're measuring, and you'll see a spike coming from the central area, that means there's abnormal activity coming from there, which means you're prone to have seizures, or there's a possibility you could have seizures in the future. But that doesn't mean there was a seizure caught on EEG. Okay. Now, if you had a ton of spikes, and then the child did something, or had a seizure, then you say, okay, that was the actual seizure, and that's an ictal event. Well, on the EEGs, we often talk about, we didn't see a seizure in your EEG, but we saw some abnormal activity on the temporal lobe. So that just means on the temporal lobe, we saw spikes, but not a seizure. But you could be prone to have seizures from that area. That's kind of what we look at on the EEGs. Now, we record for hours and hours and hours, and we look for these spikes, and we say, okay, we saw spikes in the temporal area. That means you could possibly have a seizure from that area. Now, we talk about generalized seizures. So let's say you have a bunch of brain waves, and then you have spikes all at the same time from all the electrodes. So that just means it's not coming from one side, it's coming from everywhere.
Is it possible if you remove a section of the brain where one of them is coming from, it'll reduce maybe or help the quality of life? Not have as much of as many
Yeah.
seizures in general?
Yeah?
Because I'm hearing, if it's generalized seizures, we don't do surgery, but is there any way to maybe remove it?
We want to remove where the seizures come from. Removing where the spikes come from won't be as helpful. So if you're having a generalized seizure, cutting out one part of the brain is not going to really help necessarily stop the seizures, but you want to see if the seizures come from one part.
And that's known because it's been tried in the past?
Yeah. Yeah. Please.
So for LGS, the low spikes, where would they be, or how would they interpret?
I'm sorry? Sorry.
LGS,
Yeah.
where would the low spikes?
So we look for a kind of generalized, slow spike wave pattern. That's just an EEG pattern. So you could still have focal seizures, but have a generalized spike wave pattern. So on your report, they might say, oh, the baby has slow spike wave. That just means it's the slow pattern on EEG. That's in the background, exactly. Kind of like this one in the background. This is just in the background. It really depends on how active the seizures are, the doctor's preference. If you're seizure-free and just kind of doing okay, EEG is probably not going to change unless you want to try to come off medication. So let's say you're seizure-free for like 2-3 years, you do an EEG and it's really active, then it helps me tell you, we could try to come off it, but your EEG is very active and there's a chance your seizures might come back. But if you have a new seizure type, I often do an EEG to see what that seizure looks like. So it kind of depends on the moment.
So when medicine is controlling someone's seizures, they can still have active EEGs?
Yeah.
So basically you don't see them jerking or having an absence, that's basically it?
You can have abnormal background EEG and still not have seizures, sure. So you can have abnormal activity, but not have a seizure in life or on the EEG.
So if somebody had abnormal EEGs
Yeah.
but don't have seizures, do you put them on medicine?
It depends if they had seizures in the past. So let's say you had 5 seizures. I put you on medication. You stop having seizures, but your EEG is still abnormal. That just says you're prone to have seizures. So if I take the medication away, your risk of having another seizure is back up because your EEG looks abnormal.
You have the risk, but you don't have the side effects.
Yeah, it really depends on if you want to have a seizure or yeah, it's a choice. Yeah. Yep.
You have, my kids have AD and SLE.
Okay.
Do you find that sleep apnea machines or anything help, or anything would help with that, with the sleeping?
If you have sleep abnormalities like apnea or any kind of parasomnias, it sometimes helps to see a sleep doctor, get the sleep study, see if there's any kind of interrupted sleep. Any ways to improve sleep would be beneficial. So I think it's worth trying if you haven't had a sleep study or see if they had apnea. I think my...
Do people with LGS ever have, like, trouble falling asleep? Like, is that a general symptom?
Not for LGS, no. Everyone's different. Okay. We have 5. I'm going to... Is Dr. Lawless talking next or no? Are you, no? Okay, just hang out. Okay. We have 5 minutes left. So thank you all for your time. Thank you. Okay.